The next is about the neoplasms of the vascular hematological disorders, hematological system as such. They are named as leukemia. That name comes from after 1827, and Alfred Ahmad Lewis first described leukemia in 1807, and the meaning of the word is the leukos means white and hema means blood, so something like white blood, and the name of this leukemia was established based upon this Latin word or rather Greek word, and the pathology of this was first described in 1846 as in terms of the abnormality of the white blood cells. The white blood cells in the body system are mainly of two origin, that's the myeloid and lymphoid. Myeloid, they actually all of them they origin from the blood stem cell, and in the bone marrow the cells mature, and the cells which are released from the bone marrow continuously are called as the myeloid cells, and the polymorphonuclear leukocytes, basophils, monocytes, they are considered, and eosinophils, they are considered as they are myeloid cells, whereas the lymphocytes, which will be in originally they are from the blood stem cell, and then they are located in the peripheral tissues, in different tissues, and they are lymphoid cells or lymphoblasts, which result in different types of the lymphocytes, which we call as the B lymphocytes or T lymphocytes or the routine circulating lymphocytes. Platelets also are the myeloid cells, RBCs also are the myeloid cells, and hence the tumors or the malignancies originating from the myeloid cells, they are called as myeloid leukemia, and these are the others which are produced from the lymphoid cells, they are called as lymphoid leukemia. The leukemia now is classified based upon the issue of involved cells type. The leukemia is either acute leukemia, where the clinical presentation is acute, and in the acute again either it could be acute myeloid or acute lymphoid, and there is an undifferentiated mixed type of the phenotype. Then the other is the chronic leukemia, where there could be chronic myeloid and chronic lymphoid leukemia based upon the origin of the cells. Then in addition to this, there is a lymphoma, the different types of the lymphomas, where the circulating blood may not have the abnormality, and they are again categorized into Hodgkin's lymphoma and non-Hodgkin's lymphoma. Now, as far as the leukemia is concerned, we will just start with the leukemia in the beginning and then go to the lymphoma and their different varieties as such. The leukemia is again classified in different manners. The classification itself looks a bit complicated issue. As per the 2022 WHO classification, the leukemia are classified as myeloid precursor lesions and myeloproliferative neoplasms and myelodysplastic neoplasms and myelodysplastic myeloproliferative neoplasms, mastocytosis. These are all depending upon the type of the cells which we see. But the basic would be acute myeloid leukemia. So we will be focusing on this acute myeloid leukemia and then the chronic myeloid leukemia, the other part of it. Whereas this kind of differentiation is based upon the tissue histiotypes, which is a very advanced method of diagnosing it. Then in addition to this, there are secondary myeloid neoplasms and lymphoid neoplasms. Acute leukemias are mixed or ambiguous lineage, dendritic cell histiocytes. These are what the WHO classification says. Whereas ICC classification, the names are different. Myeloproliferative disorders, myeloid or lymphoid neoplasms with eosinophilia, mastocytosis, myelodysplastic conditions, pre-malignant clonal cytopenias, or myelodysplastic syndrome alone as such, pediatric disorders or acute myeloid leukemia, myeloid proliferation with Down syndrome, blastic plasmacytoid dendritic cell neoplasm, acute leukemia are ambiguous lineage. This is about the type of leukemia. In addition to this, there is a erythroleukemia also, where the RBCs are involved. So instead of going into all that complicated classification, I will try to make it simplify and limit to the common clinical variations, which we can make out with the clinical differences and which has something related to the clinical outcome also. The other significant these details like going to the histotypes, which would be most of the times becomes somewhat unnecessary. I don't use the word unnecessary, not relevant, very much relevant in the clinical practice, in the routine clinical practice. They may have some significance only when there is a need for selection of specific the chemotherapeutic drugs or chemotherapeutic regimens. So from that point of view, we will limit the discussion and focus only on the basic issues as such. Now, as far as the first of the ring which we discussed would be acute myeloid leukemia. The acute myeloid leukemia would be, of course, as a total, in total, the leukemia constitutes around 2.5 to 3.1% of the new cancer incidences globally. Something like 2000 recent one, like as far as the 2020 data says. Acute myeloid leukemia, the incidence is comparatively high. So from the clinical point of view, important conditions are discussed in the beginning. So we will discuss the acute myeloid leukemia and chronic myeloid leukemia in the beginning, then go to the lymphoid leukemia as such. The incidence of these would be acute myeloid leukemia as per the data in 2017, 23.1% of leukemic cases are the acute myeloid leukemia. And the age standardized incidence rate of acute myeloid leukemia is around 1.35 per 1 billion in 1990, and it is 1.54 in 2017. So there is a steady increase in the number of acute myeloid leukemia patients occurring. Chronic myeloid leukemia, again the incidence is getting reduced compared to the acute myeloid leukemia. In 1980, 31.8 thousand cases were seen, and in 2017, 34.2 thousand cases were seen earlier as such. But compared to the increase in the population, this incidence ratio is reduced from 0.75 to 0.43 per lakh population. Lymphocytic leukemia, again, the average lifetime risk of getting a lymphocytic leukemia is around 1 in 1000. So incidence of lymphocytic leukemia also is somewhat more common, and it's more common in white people than the African and Americans. So first we discuss about the acute myeloid leukemia. Acute myeloid leukemia, as per the estimates of USA, now this kind of a data is not available from our Indian these resources. From USA, the incidence is expected to be in 2024. The estimates of acute myeloid leukemia is considered to be 20,800 people with the acute myeloid leukemia, and 11,220 would be dying due to the acute myeloid leukemia. So the fatality rate is comparatively high, and those patients who die would be adults. Majority of them are adults, as the source there. The median age of newly diagnosed acute myeloid leukemia in India, from Indian data, whatever we get the data from different sources, is around 40 years, and the median duration of symptoms before the first presentation is about 4 weeks. So till after the symptoms are seen, for the diagnosis it takes about minimum average of 4 weeks in Indian situation, and the overall survival rate at 1 year is 70.4% for patients aged equal to or less than 15 years, whereas 55.6% for patients with the aged 15 to 60 years, and 42.4% for aged above 60 years. This is from the sources, from Indian sources. Incidence from the global point of view, Asia is one area, Asian region, and Australia, of course some part of Southern America. These are the areas where the incidence is higher in case of acute myeloid leukemia. From the other resources which we get from the Indian source, now though we may not get an accurate incidence of the diseases, the calculated or predicted leukemia market, that the market value of treating leukemia is increasing, and it's increasing by 2030. It's expected to be reaching to 64 millions as such. Now that's about the incidence epidemiology. Now as per the pathology is concerned, The myeloid leukemia would be resulting in the bone marrow pathology, and this results in two sorts of the disease processes. One is the normal blood cells which are produced from the bone marrow. They are reduced. The normal blood cells number would be reduced, and hence the patient would result in the patient would have anemia or thrombocytopenia or neutropenia. So some of those normal cells will be reduced. At the same time, there will be rapid proliferation of the myeloblasts. The myeloblasts, which are premature cells, and they are identified by their morphology. The myeloblasts are large cells with round nuclei, whereas an adult or WBC would have, see, in case of polymorphonuclear leukocytes, the WBC would have lobulated nucleus, and the basophils, again there will be small curved nucleus as such. So by identification of these features, we identify whether it's a blast cell or not. These blast cells, which are premature cells, they are released from the bone marrow immature conditions, and they have a capacity to avoid the apoptosis. They do not die easily. This results in a large number of these cells in the bone marrow as well as in the blood, and also in the spleen and liver, and this results in the what we call as the myeloid leukemia. So myeloblast would be the important issue. Identification of these myeloblasts are either by the large nucleus which is present, or the R rods, that the nuclear material which is presented something like the rods would be seen. And the global incidence of acute myeloid leukemia is estimated to be around 1.54 cases per 1 lakh per year, with significant regional variations. Now myeloid leukemia again is subclassified into multiple varieties based upon the tissue typing. Again, this also is a very complicated issue. Based upon the etiology, the myeloid leukemia incidence is more common after a chemotherapy or radiotherapy for some other lesions, neoplastic lesions. So from the WHO classification, one category is myeloid neoplasm post-cytotoxic therapy, the lesions which occur after the chemotherapy. Another group of the conditions were what we call as myelodysplastic syndromes. Now myelodysplastic syndrome is those conditions where there is an abnormal myeloblast, but the number of myeloblast cells are supposed to be less than 20%. Now again, that 20% or otherwise also is being disputed till maybe last 10 years, something around 2019 or up to around 2020, the cutoff for the myelodysplastic syndrome was 20%, less than 20% of the myeloblast. They were considered as the myelodysplasia. But now it is reduced to 10%. If it is less than 10%, then it will be myelodysplasia. If it is more than 10%, it is called as leukemia. So it is only the nomenclature in terms of the number of the myeloblasts seen in the periphery. So premature cells, their number or ratio to the normal cells. If it is less than 10%, now as per the current classification, they are called as myelodysplasia. The difference is myelodysplasia and the leukemia is leukemia requires a specific chemotherapy treatment, whereas dysplasia doesn't require a chemotherapy treatment. You can wait and watch, and maybe supportive treatment would be necessary. Now even in that myelodysplasia, now based upon the tissue typing, the changes in the tissues and the genes over there, it's further subclassified into many groups. This would be possible only when you go for the genetic study. The specific genes with a code name like RUNX, RUN, X1 or CBFB. Now these issues are, which again based upon the advanced genetics, which may not be used in the routine clinical practice. Only for the research purposes they are used. So we will not go into the detail of that. We will categorize only this myelodysplastic syndrome from the clinical point of view. Another way of classification would be based upon the differentiation, the pattern of the cells. if the cells have a minimal differentiation by the shape of the myeloblasts, or the myeloblasts without maturation, or myeloblasts with the maturation, or acute basophilic leukemia, or myelomonocytic leukemia, depending upon the type of the cell, and monocytic leukemia. Then of course, as per the WHO classification, erythroid leukemia also is categorized in the acute myeloid leukemia, where the RBCs are increased, but this also is another controversial issue, whether erythroid leukemia has to be considered as such or not. Erythroid leukemia has to be considered as a separate issue. That's the point of controversy. We will not go into that part. But the differentiation of the cells based upon the character of the cells, they are again subclassified. Now, as far as the causes are concerned, for the myeloid leukemia, the myelodysplastic syndrome is considered as a cause of the leukemia, because a bone marrow disease, the myelodysplastic syndrome is classified as myelodysplastic syndrome. We have discussed about the classification where the genetic abnormalities are listed, and it's defined as a bone marrow disease of unknown etiology that occurs most often in older patients and manifests in a progressive cytopenia, that's a reduced number of RBCs over months to years, a prolonged duration, which tends to occur. The number of cells would be reduced, and the other aspect would be alkaline phosphatase tends to be increased in such patients, older patients who have a raised alkaline phosphatase level, and the number of WBCs being reduced, and the peripheral tissue, this smear study either may show abnormal myeloblasts, or even they show in lesser numbers, that's less than 10%. They are classified as myelodysplastic syndrome, and myelodysplastic syndromes are considered as a precursors to the leukemia. In due course of time, they may develop into the leukemia later, and hence it is considered as also an etiology for the leukemia. Patients of aplastic anemia, where again there is already a bone marrow pathology because of the anemia as such, or rather the anemia is produced as a bone marrow pathology. Aplastic anemia is also considered as a etiological factor for the myeloid leukemia. Congenital diseases like Down syndrome, neurofibromatosis also increase the chances of there is a statistical incidence of these. The environmental exposure to radiation, benzene, smoking, and exposure to chemotherapeutic agents also are considered as causes of the leukemia. Now, again, the same issue which we have discussed now, the genetic factors, presence of abnormality of the genes also are considered as the causes of leukemia, and rather this is given lot of importance now. Genetic studies of different abnormalities of genes. Now these again NPL mutation or chromatin or these different types of genetic abnormalities which are listed, they are mainly done in very advanced centers, not in the routine clinical practice, and these studies would be giving some idea about the prognosis. As per the data, again though this is not routinely used in the clinical practice, as per the data, the genetic abnormalities of T8 into 21 and T15, 17 would have a better prognosis, whereas FAT3 mutation would have a poor prognosis. So to predict the prognosis, genetic studies also are used, and these abnormality of genes can be a cause for the myeloid leukemia. And those persons who have these abnormal mutations of the genes, they could be warned about, or they could be predicted about the possibility of leukemia developing later. And the symptoms of acute myeloid leukemia, the symptoms which occur mainly would be due to two factors, either due to bone marrow failure, or the other is organ infiltration with the leukemic cells, or both. The patients may have both. The bone marrow failure results in anemia, neutropenia, that's the normal WBC count would be reduced, whereas abnormal cells would be higher, and thrombocytopenia, that the platelets count also would be reduced. As a result of that, the patients would have a susceptibility to infections. Symptoms of anemia like dyspnea on exertion, tiredness, fatigue, etc. also could be the symptoms. Thrombocytopenia can result in bleeding as such. So majority of the patients, they present with these symptoms like fatigue or susceptibility to infections or the bleeding tendencies from different sources of the body. The organ infiltration of leukemic cells, which often involves the spleen, liver, gums, and skin. And as a result of this, there could be splenomegaly, hepatomegaly, and then of course the gums also would be bleeding. Skin, there could be typical skin lesions, where there could be erythematous lesions occurring in case of myeloid leukemia. Even subcutaneous bleeding spots could occur. And the infiltration most commonly occurs with that AML subtype, that monocytic subtypes, like where there could be monocyte involvement of the cells, then there would be the incidence of infiltration of tissues would be more common. Splenomegaly may also have the symptoms like a mass present in the upper abdomen, particularly splenic size, left upper quadrant. A good number of patients may not have any other symptom except for the visible or palpable mass at the left side due to the involvement of the spleen as such. And the patients with gum infiltration present with to their dentist first with gingivitis or neutropenia can cause swollen gums, and thrombocytopenia can cause the gums to bleed. Patient with markedly elevated WBC count, more than 1 lakh cells per milliliter, can present with symptoms of leukostasis, that's respiratory distress or altered mental status. So some of the patients may have a very high WBC cells, but normal WBC cells will be reduced. So there is a neutropenia, but at the same time, the total number of WBCs will be very high. Patients with the high leukemic cells burden may present with bone pain due to increase in the bone marrow pressure, or there is a tendency for the yellow bone marrow to get converted into red marrow, and hence the patient may have pain in the bones also as the symptoms. Other signs which could be accompanying a patient of acute myeloid leukemia could be cardiac hemic murmur in anemic patients, lung findings suggestive of pneumonia due to the susceptibility to infections, petechiae particularly in the lower extremities due to thrombocytopenia, or signs relating to organ infiltration like hepatosplenomegaly and lymphadenopathy also may occur. The confirmation of the diagnosis is mainly based upon the peripheral smear examination. Now, peripheral smear examination, the pathologist should be able to identify these abnormal cells at their different phases. Morphology of stem cell, the size of the stem cell would be around 40 microns, quite big cells. Then gradually as they come down, the size becomes reduced. The nuclear material also, the density of the nuclear material gradually reduces. Shape of the nucleus would be changed when an adult or a normal cell of the periphery, the nucleus will be lobulated. Whereas the blast cells which are present in the earliest category, the nucleus will be lobulated and the size will be quite big in the beginning and gradually it becomes reduced. And these different phases are identified in the peripheral smear. So ultimately the diagnosis will be based upon what you see in the peripheral smear, the cells with the large nuclei and the lesser space around perinuclear halo, and then the R rods in the blast cells. The blast cells will have that specific nuclear material which is looking like rods over the area, and identification of these is the basic method of diagnosis of leukemia. Then the other investigations which may be necessary would be bone marrow aspiration and biopsy, analysis of genetic abnormalities. Now that genetic abnormality analysis itself is a very huge job which is not done routinely, only in advanced centers that's done, but now it's gaining popularity, and this genetic abnormality study would be helping in predicting the prognosis as well as maybe at times selection of the drugs or regimes which could be used. Among the blood tests, in addition to that peripheral smear examination, alkaline phosphatase enzymes level also can be a criteria for the pneumonia, these leukemia conditions as such. Imaging studies have a very less role in case of myeloid leukemia, only the bone marrow examination as such. Now, there is a the same defined by 2022 that guideline algorithm to make the diagnosis based upon the present day's classification is published now, but most of the times these are not really followed. The different types of the classification, WHO 2022 classification, ICC 2022 classification, mixed together. Now there is one more EUN classification also done to make out that the diagnosis would be first the morphology of the RBCs are studied, then the cytogenetic analysis, this assessment of the tissue types are done, and then the immunotherapy phenotypes, the immunological changes which have occurred also are studied, and the molecular biology also helps in. These are the different steps to help in the diagnosis, and the total time taken for this kind of a study is something like 28 days as per the standard, which is a very high standard practice, which is not really practiced, but I am just referring to these issues because these are maybe the chances of the future. Now the incidence of this, now with the limited issue of examining the peripheral smear and their cell patterns, the incidence would be acute myeloid leukemia with the minimal differentiation. That's the WHO classification based upon the differentiation pattern. Is around 20%, and acute myeloid leukemia with the maturation is around 25%. So the number of incidents that we see quite frequently are the acute myeloid leukemia with the maturation, that the blasts will show the signs of maturation, or with the differentiation, minimal differentiation, or monocytic leukemia. These are the major types of the leukemias which we see. The without maturation or basophilic leukemia and the erythroid leukemia or megakaryoblast leukemia, they are lesser in number what we see. So majority of the patients, they come under the acute myeloid leukemia with maturation or with the minimal differentiation. Treatment options for the acute myeloid leukemia is mainly either chemotherapeutic agents, and the chemotherapeutic agents which are now the latest, the current trend of selection of the drugs in general, in specific, would be the ibrabicin and danirubicin or myoxantrone. The schedules are already there, or the other newer generation drugs like biological agents like venetoclax also is becoming quite popular. Ultimately, in a patient who doesn't respond to the usual chemotherapy is treated with the stem cell transplantation as such. So that's about the acute myeloid leukemia. The next part which we discuss would be the chronic myelogenous leukemia or chronic myeloid leukemia. Chronic is nomenclature, again there would be lot of difference in the these confusions in the nomenclature. Either myelogenous or myeloid, that doesn't make much difference. Is characterized by increased proliferation of the granulocytic cell line without loss of their capacity to differentiate. So the cells, they resemble that of the normal cells, like physical as per the shape morphologically, unlike that of acute leukemia. Acute leukemia, the blast cells will be seen, whereas in the chronic myeloid leukemia, the granulocytic cells will be increased in number. Granulocytes are polymorphonuclear and eosinophil cells. Their number will be increased and they seem to be looking morphologically, they look to be somewhat near to normal, but of course the characters are different. And the chronic myeloid leukemia incidence is around 95% of the total is 35,830 in compared to in the total population in 1990, and the total percentage change in incidence has decreased in high socioeconomic index countries, that high index countries as Western developed countries, whereas in the incidence of chronic myelogenous leukemia is increasing in the middle, low and lower SDA countries. That's like India, the incidence is increasing. Western countries, the chronic myeloid leukemia its number is reducing. Now, why and how, this we do not know. As per the current data, 5-year survival rate of chronic myeloid leukemia is around 90%. The current treatment protocol has produced a significant change in the outcome, and the 5-year rate has been more than doubled from 31% in the early 90s to 70.6% for the patients diagnosed from 2013 to, that's due to the that karyocytic telomerase kinase inhibitors. Telomerase kinase inhibitors drugs, newer drugs are introduced, and that makes a change in the total outcome. And one more important issue is more than 90% of the cases due to they occur due to a abnormal chromosome, which is also named as a Philadelphia chromosome, and this accounts for around 20% of the conditions. In a myelogenous leukemia smear study, the smear will show immature granulocytes, which otherwise they are not granulocytes, and the immature granulocytes would be seen as a promyelocytes. The size of these cells would be bigger. The normal WBC would have a diameter of around 16 microns, whereas these would have a diameter of 25 to 30 microns. This diameter will be bigger. The lobulations in the nucleus would be lesser. The normal cell would have a nucleus which is fully lobulated, where the numbers of lobes can be counted like 2 or 3, whereas these lobulation would be lesser. And they are based upon their stage, they are named as either promyelocytes or metamyelocytes. That myelocytes, depending upon this, they are named as such, and their number would be increased, and the total number of WBCs would be enormously increased as such. The chronic myeloid leukemia is clinically identified under 3 phases, that chronic, accelerated, or blast phase. Blast phase resembles that of acute myeloblastic leukemia as such. Approximately 85% of the patients are diagnosed in the chronic phase, and during the course of the disease, they may develop into a accelerated phase where the number of cells would be increased as such, and then they may even develop a blast phase, which is a very advanced stage as such. So about 85% of the patients, majority of the patients whom we see would be diagnosed at the initial chronic phase, and it may take change over the time, like it may take from a acute chronic phase may result in accelerated phase. It may take some time, like around 2 to 3 years, or at times it could be around 5 years. As 3 to 5 years is the average time taken for conversion of that acute chronic phase to an accelerated phase. And there is also a latent phase, which is identified by the identification of the genetic patterns. So genes abnormalities, they identify a wider earlier diagnosis of a latent phase, where the blast cells would be, and this all again depending upon the number of blast cells. Blast cells less than 3% is considered as the latent phase. Blast cells in between 3 to 10% are considered as the chronic phase. Blast cells in between 10 to 20% are considered as accelerated phase, and when the blast cells number is more than 20%, they are categorized as a blast phase as such. And the same WHO definition of the same phases would be, this is the WHO phase definition. In the chronic phase, the blast cells will be less than 10%. In the accelerated phase, the blast comprising 10 to 19% of the white blood cells in peripheral blood or bone marrow cells. Peripheral blood myeloblasts and promyelocytes combined would be less than 30%, and peripheral blood basophils will be less than 20%. Persistent thrombocytopenia unrelated to therapy, where it's not after the drug, or persistent thrombocytosis, either increased number of platelets or reduced number of platelets, also is considered as the accelerated phase. And increased WBC count and spleen size, which doesn't respond to the usual therapy, and cytogenetic abnormalities of Philadelphia chromosome is also a criteria to make the diagnosis of accelerated phase. Blast crisis, that blast phase is considered also as a crisis, which becomes which results in medical emergencies. Most of the times the outcome will be very poor once it reaches the blast crisis level. The blast cells will be more than 20% of the peripheral blood smear studies, and there could be a blast proliferation in the bone marrow. So when you do the bone marrow study, you will be seeing that, and the bone marrow will be showing that blast acid. And as I told you, there is a lot of confusion about the nomenclature. The nomenclature will be chronic myeloid leukemia with the Philadelphia chromosome. Now, This again, from the clinical point of view, it's not important, but when we see some documents or some records of the hospitals, some other hospitals like patients who come to you, you will find these different nomenclatures which need not be confused. They are all synonyms. The Philadelphia chromosome positive CML with these the numbers which are suggestive of the specific genes which are abnormality, or chronic granulocytic leukemia with the chromosome positive, and chronic granulocytic leukemia with the specific genetic abnormality. These are all the terminologies which are often used in advanced centers for the same disease condition, which need not be confused. That's all the part. And ICD code also is again confusing. Chronic myeloid leukemia, which is not classified elsewhere, is the code is 2B33.2, and the specified leukemia, the code is different. So these issues, chronic myeloid leukemia, simple, with the specific genetic abnormality T9 is the code is different. Now this again makes the issues bit very confusing, like. So I think that's not necessary. We need not bother much about those issues, the very final issues. The important would be to make the diagnosis of a myeloid leukemia as early as possible. The predisposing factors for pediatric chronic myeloid leukemia are not known. Of course, genetic abnormalities are given the importance. Otherwise, other than that of genetic abnormalities, the real causes are not known. Ionizing radiation is considered as a rare risk factor in adults, and the maximum increase in myeloid leukemia incidence was observed in Hiroshima after the atomic bomb, and in a median time of 6 years. But the same has not occurred in Chernobyl after the nuclear plant accident. So whether that's the issue of controversy, whether the radiation is a cause for the myeloid leukemia or not, is the issue of controversy. Again, not yet proved, but most possibly radiation could be one of the causes. And the clinical presentation of chronic myeloid leukemia, majority of the patients in the chronic phase would be totally asymptomatic, and they are discovered accidentally in chronic phase when the blood cells are abnormal, and the blood cell is done, blood cell study, routine blood cell is done for some other purpose, or the patient may present with a spleen enlarged, which again becomes maybe asymptomatic as such. The other symptoms when they occur could be fatigue, weight loss, a loss of energy, decreased exercise tolerance, which are vague symptoms which may not really lead to the real causes. Low grade fever, excessive sweating due to hypermetabolism. That's also another of the symptoms which often can occur. Patient may have a low grade fever, excess of sweating occurring. And the blood cell count may be increased along with the splenomegaly, and routine assessment also could be the other feature. Early satiety, that's the reduced food intake, and due to the compression of the stomach due to spleen, enlarged spleen. Upper quadrant abdominal pain with the splenic infection, hepatomegaly could be the symptoms. When you do the peripheral study, based upon the now the leukocyte count could be increased due to other reasons also. Now, how to make out that when the peripheral leukocyte count is studied, leukocyte morphology is studied, a myeloblast would be bigger, and then it would have a nucleus which is almost occupying 90% of the area. Promyelocyte, the nucleus is roundish, whereas the segmented granulocyte is adult. In the normal condition, you will not see any myeloblast. The banded granulocytes may be seen in a few number. Very rarely a metamyelocyte could be seen in a normal distribution. So when you look at the peripheral smear study, normal count would be almost 99% would be the advanced that developed WBCs. When there is an infection, there also could be an increased number of WBCs, but that number of WBC, leukocytosis, may result in an increase in the number of that mature WBCs, plus a few of that premature. The next previous steps like granted granulocytes may be seen. Whereas in a chronic myeloid leukemia, there is a complete shift. All the types of the lesion cells, starting from the blast cells to the median variety, the middle variety, myelocytes, and actually it's the myelocytes and metalomyelocytes which are increasing in number. In acute myeloid leukemia, it's blast cells which are increased in number, whereas the normal pattern, their number may be either reduced or they may be in the normal limits. So by looking at that pattern of the distribution of the different types of the cells, the diagnosis of acute myeloid leukemia and chronic myeloid leukemia can be made, and this is the standard initial protocol of making the diagnosis of either chronic or acute myeloid leukemia. Though the present day situation, you will have a lot of other issues like genetic studies, immunological studies as such. The symptoms of a progressive disease, accelerated disease would be a chronic phase, the symptoms will be asymptomatic, or it will be only the splenomegaly, vague symptoms like fatigue. Whereas in the accelerated progressive phase, the patient may have bleeding, rashes, ecchymosis, and bone pain or fever, which may occur in the later blast phase, anemia which becomes more progressive, thrombocytopenia, and complications of the same, and it may even result in a blast crisis, acute blastic crisis, where the rapidly enlarging spleen may produce either pain or rupture as such. Blast phase, when more than 30% of the blood cells in the bone marrow are blast cells, it may present with the bone and joint pain, pain in the bones as well as abdomen. So, spleen is enormously enlarged, and bleeding, the unusual bleeding from the nose or bleeding gums, infections, repeated infections tend to occur, fever as a constitutional symptom, night sweats also could be seen as such. Now, bone marrow findings are the most other dependable findings, and bone marrow findings also help in prediction. The bone marrow study is one of the next step in the diagnosis of the chronic myeloid leukemia, and based upon the changes in the bone marrow, the prognosis can be predicted. Also, the disease progress also can be predicted based on the type of the cells distribution or pattern which you see under the microscope. It may be considered as the myelofibrosis or reduced cellularity. The cellular number of cells could be reduced. The major microscopic abnormalities in the bone marrow are the three disease phase, myelofibrosis or cellularity. Then the other is about the genetic studies. If the genetic studies show the Philadelphia chromosome, then they are one of the issues of the diagnosis. Now, what I mean to say by this disease phase and proliferative phase, accelerated this myelofibrosis is the last slide shows the myelofibrosis where the myelofibrosis tissue is seen. In the normal bone marrow, a few of the blast cells could be seen, whereas in a bone marrow with the neoplasm, this acute chronic myeloid leukemia shows the number of blast cells which is more than 70% or nearing to 70%. That's how it is seen under the microscope. So ultimately, the pathologist has a major role in making the diagnosis. Now, other characteristic features occasionally which could be helpful in the diagnosis would be when a MRI scan of the bones are done, that a typical degenerative changes, and very commonly in the vertebral body, it can occur, the modic type of degenerations can occur in the other bones also. The modic type lesion, that's where there will be a thick border of sclerosis and a degeneration in the this subperiosteal area, which involves both the bones, the close near a joint. That is called as a Mobic type 2 type of the lesion, and that would be a characteristic feature seen in the microscope or seen in MRI scan. PET scan also shows the abnormal bone marrow uptake, the FDG uptake, that metabolic activity would be either lesser in some areas, they will not be uniform. Some areas it will be lesser, some areas it will be more, and this inhomogeneous type of the distribution of the density is also a characteristic feature of the chronic myeloid leukemia. Now, chronic myeloid leukemia grading is very difficult, and to make out that a lot of that two different types of grading are done to predict the prognosis, and this is also helps in the ratio possibility of hazards like complications which can occur. And the one is the Sokal score based upon one device by Dr. Joseph Sokal, which is quite popular now in majority of the oncological discipline. This is done, and it's calculated by the age expected, that's 43, and then you have the expression of the age plus spleen size in centimeter multiplied by 0.0345, age multiplied by 0.0116, and platelet count multiplied 0.188, and blast in the blood multiplied by 0.087. Now this becomes again very complicated issue. You need a big calculator and many times you get an error. But to avoid this, there are some facilities now already. Some websites are there where you enter the data, you get the score accent. I will show that URL of the data, the screenshot of that. This would be the for so-called score. You have a website where you insert these or add these facts like age, then the spleen size and platelet count, myeloblasts in the periphery, and then you click, you get the result as such. Which is a free site. So this can be used if at all you are interested. In a patient comes to you, instead of going for this calculation, you may go to the site and then predict the prognosis. And the prognosis is if the score is less than 0.8, the risks are lesser. If the score is between 0.8 to 1.2, there is a intermediate risk, and if it is more than 1.2, it's a high risk as such. And the treatment, the patient would be having a complete resolution when you treat in the low risk groups. 91% would have a complete resolution, 84% would have complete resolution in intermediate group, high risk patient would have 69%. Now there is another type of this calculation also, which is now becoming rather a trend now, and this is called as ELTSR, European long-term survival this prediction. There is a combined European treatment and outcome study as well as a European long-term survival calculation. This also is based upon a similar issue of calculation where these figures are something different. Now these figures are derived based upon the statistical analysis. Now for this also you have another website where this user's score also can be done in the similar manner, where you insert these numbers and then you get the data, and the prediction of the prognosis is possible. As far as the treatment is concerned, now the current trend of the treatment is from 2001, the tyrosine kinase inhibitor, that's imatinib, was approved as the treatment, and that has produced a significant change in the outcome. And it's the outcome would be there is a complete hematological remission, cytogenetic remission, that's the Philadelphia chromosome also can be modified as such, and molecular remission, the changes in the metabolic activity also is possible with the tyrosine kinase inhibitors. And among them, imatinib is one of the usual remedies. Now, as far as the evolution of the treatment for chronic myeloid leukemia concerned, earlier 1840, the first concept of leukemia was developed as such, and the arsenic was used as a treatment for leukemia. Now, I refer to this issue for some other reason. Then gradually the different choices were made from 1970 onwards. Different drugs were used. Hydroxyurea was used in 1970. Then transplantation therapy was tried in later parts of the 70s. Interferon was used later, and imatinib started in something around 2000. The results, there is a big data, huge data coming up. Compared to these results, the survival rate in early phase 1980s was 18%. Now the survival rate, that's the cure rate is 92%. So chronic myeloid leukemia is now considered as a curative treatment. Now arsenic was used earlier, but now the arsenic is not used because you have better drug. But there are certain Ayurvedic remedies containing arsenic which were used earlier also, which are used now, and some people claim that the chronic myeloid leukemia can be cured. But it because a majority of those drugs which are used as which are popularly claimed to be beneficial in the treatment of myeloid leukemia are arsenic containing compounds. I will not go beyond that. The current, again, the latest would be nimetanib. Now you have many of the newer these molecules also, which are now being used. All that difference would be mainly the cost effect, and of course they say that they claim that these derivatives of nimetanib are specifically used for the genetic mutation. So the whole treatment of myeloid leukemia has become very complicated issue. With this we will conclude today, and in the next we continue with the lymphoblastic leukemias. Right. There are no questions. So we will wind up today.